Welcome everyone to today's webinar discussion. I'm Morgan Hafner with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the presentation by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. At this time, it is my pleasure to kick things off by introducing our four presenters. First is Dr. Kevin Koss. He is the Chief Wellness Officer for the Community Physician Network and co-founded the Center of Physician Wellbeing and Professional Development for the Community Health Network in 2017. He leads the Cabinet for the Exceptional Practice Experience and the Physician Wellbeing Advisory Council. In addition to this role, he practices internal medicine on the northeast side of Indianapolis and has served for many years as a group practice director. Next is Ann Ostrom. She serves as Director for Physician Leadership and Wellbeing for Community Health Network. In this role, Ann has helped create and establish the programs of the Center for Physician Wellbeing and Professional Development. Ann has previously held management roles in leadership development and HR. She also led the training function for the 2012 EPIC implementation for Community Health Network, which lends an appreciation for the provider EMR world. Her expertise lies in leadership and curriculum development, adult learning, and facilitation. Next is Dr. Tricia Hearn. Dr. Hearn is the Vice President of Improvement and Physician Leadership Development at Community Health Network in Indianapolis. She created and leads a 12-month Physician Leadership Academy for medical directors. The academy is currently in its third cohort. She also co-founded the Center for Physician Wellbeing and Professional Development at Community Health Network with the Chief Wellness Officer. Her expertise lies in leadership development, improvement, and organizational learning. And to bring us home is Dr. Catherine Demuth. She is the Midwest Market Medical Executive for Cigna Healthcare. She provides medical leadership to the insurer's 5-state Midwest market. Dr. Demuth is responsible for supporting physician and hospital collaboration, new business development, client retention, Midwest strategy, and financial planning. As a leader of the Midwest clinical team, she helps to identify and implement solutions to improve health outcomes for Cigna customers while delivering value for Cigna clients. At this time, I'm pleased to turn the floor over to Dr. Demuth to begin today's presentation.
Well, thank you, Morgan, and thank you to our panelists for joining us today for a topic that is very personal to those of us in healthcare because we've seen the impact of burnout on our colleagues and friends. I was first introduced to the team at Community Health Network when I was speaking to a competitor of theirs in Indianapolis about efforts to address physician burnout. And they mentioned the community had the best program. And I have to say, having a competitor tout you as the best is one of the highest compliments you can get. So in addition to the personal impact on physicians, we know that physician burnout has consequences for the whole healthcare industry. The impact is seen in physician turnover, job satisfaction, prevalence of substance use disorder, medical error, and overall quality of care. The American Medical Association found in 2017 that almost 44% of physicians reported at least one symptom of burnout in comparison to about 28% of the U.S. population. And we originally prepared this discussion for the Becker's annual hospital review in early April, which was canceled due to the pandemic, and we know that the pandemic has made things even worse. According to a September article in Modern Healthcare, almost 60% of physicians are feeling the effect of burnout, and that may even be an underestimate of the impact of COVID on our frontline caregivers. So let me turn the presentation over to the community team to hear how they build a robust physician well-being program and how they adapted their efforts to accommodate the COVID-19 pandemic. Dr. Hearn, take it away.
Thank you very much, Dr. Demuth, and thank you to Becker's and Cigna for supporting this. We are really honored to be here today to talk about our journey over the past 3 years at Community Health Network to help support both physician well-being and leadership development of our physicians. So let us first just share a little bit about our organization. Community Health Network is a non-for-profit healthcare organization in central Indiana that is, kind of a standalone network that's been around for about 50 or 60 years. We have 5 or 6 hospitals across the region that we cover with about 2,500 physicians on our medical staff. And if you consider our employed physicians and APPs, that's just over 1,000. We have over 200 ambulatory sites of care and provide, full spectrum medical care across the region. And at our health network, we were really fortunate that about 3 or 4 years ago, the initiative and imperative to have this work start to occur really came from our most senior leaders in the organization. And I think that's one of our critical success factors. Our CEO, our chief physician executive, the board of directors of our employed physician group, they all saw that it was most critical for us to resource work related to addressing physician burnout. We realized that if we didn't do some work in this area, we were going to be at risk for losing providers due to them deciding to exit the workforce. And we really needed physicians engaged in the work of improving our organization. And it's very hard to have engaged physicians when they're feeling burnout, obviously. It's a moral imperative that the system that we have created in healthcare is very challenging in some ways, a lot of administrative burdens, and we felt it was our duty as an organization to try to figure out how to remove some of those pain points for our providers, and felt that it was just the right thing to do. And at the same time, we realized that burnout was such a critical success factor for us to start to address and for our long-term strategy as an organization. We also saw the need that we really needed engaged physician leaders to help transform our organization. The only way to change and evolve in healthcare, we need our administrative leaders, but we have to have clinician leaders at the table to help drive improvement, to help reduce clinical variation, all the things that all healthcare organizations are trying to do. And we saw a gap that many of our physician leaders just didn't have the training and skills and background needed to step into that leadership role. And what the data also shows nationally, that if you have very high functioning, well-trained physician leaders exhibiting positive leadership behaviors, you actually improve the well-being of the frontline caregivers that they lead, improve their engagement, and improve their overall career satisfaction. And so it was at this time, because of this imperative from our leadership, that we saw the opportunity to blend together these initiatives, that we needed to address both well-being from a system perspective as well as leadership development, and put that all together and founded our Center for Physician Wellbeing and Professional Development in 2017. And the team that's on the call with me today, Dr. Koss and Ann, we were the founding members, and we've maintained that steady team over the past 3 to 4 years, and we will be sharing with you our journey today. So the 4 main goals of our center are shown here in the slide. That we wanted to reduce and alleviate stress that occurs for our providers as a part of the system of care, but also a part of isolation and different other factors that happen to physicians. We wanted to improve their work-life integration. We really also wanted to provide opportunities to develop physician leaders, to coach them, to mentor them, and not just those folks in medical director roles, but really all physicians need some development and coaching and mentoring as they go through their career and find that they have different needs and desires and passions that they want to meet at those different stages of their career, and ultimately to restore the joy of practice so that people can come back to the reason that they were drawn to medicine in the first place and experience that true satisfaction in the work that they do. So now I'd like to turn it over to Dr. Koss, our Chief Wellness Officer, so he can focus on a lot of the well-being efforts that we have undertaken at our center. Dr. Koss?
Thanks, Dr. Hearn. Fortunately, there is some good news to report regarding physician well-being. Healthcare organizations are finally moving away from focusing on efforts directed at promoting personal resilience and finally recognizing that physician burnout is largely the result of a severely dysfunctional healthcare system. Efforts supporting physician well-being really require comprehensive organizational, systemic, and cultural change. At Community, we've designed our well-being strategy around what we refer to as our career fulfillment model. As we developed a strategic plan for the center, we identified 4 critical domains that we felt we could lead and influence. The model builds on the Stanford Professional Fulfillment Model by adding the component of a physician leadership development program. Research shows that strong and effective frontline physician leaders significantly impact the well-being and career satisfaction of those they lead. We believe that by adding this leadership development program, we create great synergy with our other well-being domains. Also want to point out that the proportionality of our model is really deliberate. It's estimated that about 70 to 80% of the drivers of physician burnout are related to the work environment. The arrows represent the reciprocal relationships between each of the domains. Our goal is not to just simply reduce burnout, but to restore joy and meaning to the practice of medicine. Over the next few minutes, we're going to highlight some of the initiatives that we feel we've had the greatest impact on physician well-being. One of the first questions healthcare organizations need to ask themselves is, what is the current culture of your organization? And what is the state of your organizational readiness to change? Do you have a culture of shame and blame, or one of psychological safety and accountability? Without emotional safety, people are forced to protect themselves. Unfortunately, this is only going to increase their sense of isolation, leading to more risk of depression and burnout. Fortunately, in 2017, our network board and executive leadership team recognized the impact and scope of physician burnout and established physician well-being as a strategic priority, as well as providing dedicated resources to help establish our Center for Physician Well-being and Professional Development. Our first goal was to really establish and promote a culture that truly supports physician well-being. Our early strategy was to transform our culture by identifying key stakeholders and providing them education about physician burnout, its impact on our physicians, as well as how that negatively affects our ability to provide high-quality patient care. We then invited these stakeholders, which included our marketing, IT, informatics, and recruiting teams, academic affairs, representatives from the Marion University College of Osteopathic Medicine, our foundation, executive leadership team, all of our physicians and advanced practice providers, including their spouses, to a dinner and a keynote address on the topic of physician burnout by a nationally recognized speaker. We focused on 3 goals: increasing self-awareness of how to recognize signs and symptoms of burnout, understanding how burnout affects physicians' personal and professional lives, and finally, we shared data with everyone on how burnout negatively affects our ability to take care of our patients. A true culture of wellness exists when you provide space and appropriate resources that promote valuing ourselves, our colleagues and staff, and our personal relationships. At the onset, we also established a well-being advisory council comprised of frontline physicians, both employed and independent, representing various specialties and regions within our network. This well-being council helps us set strategy, identify well-being gaps, host events, and help communicate available resources. Historically, healthcare organizations have invested heavily in shaping and optimizing the patient experience without really recognizing the needs of the caregivers. Last year, one of our major initiatives was to create what we call the exceptional practice experience. We wanted to leverage our people, processes, and technology to really improve the work environment of our physicians. We first started by surveying our physicians and identifying their pain points. And not surprisingly, these seem to align with all of our physicians nationally. Our physicians' top 3 concerns were too much work after work, excessive administrative tasks, and a perceived lack of control over their workload. Our goal was to establish a manageable cockpit, a concept that's been described by Dr. Christine Sinsky, who's currently AMA Vice President of Professional Satisfaction. Too much time that's spent on the computer and not with patients, resulting in a transactional rather than a relationship-based care model, is a major dissatisfier for both physicians and patients. And there's extensive research that supports these concerns. Time studies have found that for every hour physicians spend on direct patient care, they're spending 2 hours on documentation and administrative work, and that's not to mention the 1 to 2 additional hours they're spending at home charting. It's estimated that physicians are spending up to 80% of their time in the electronic health record, hunting and gathering data rather than really interpreting it for patient care. Unfortunately, the electronic health record focuses on doing things right rather than doing the right things. So we identified 4 key areas to help us address the inefficient and chaotic workplace environment many of our physicians are dealing with daily. And these are top of profession, best practice, technology optimization, and provider communication. We then established a governance structure to try to help lead the work. We formed what we call our EAP cabinet, which set strategy, identified priorities, and helped drive the processes and outcome improvements. Our individual councils are organized as dyads with a physician and an administrative lead whose role is to turn those priorities into actions and oversee the activities of our empowered work groups. These interdisciplinary work groups identify initiatives to pilot and test and report back the results. Today, I'd like to discuss the work of 2 of the 4 councils. A major focus last year was in the area of technology optimization. One initiative that was an instant success for all caregivers was the implementation of single sign-on, which allowed us to use our ID badge rather than a keyboard to log into our workstations, and we called this our tap-in, tap-out initiative. We made this available to all caregivers. It eliminated thousands of clicks and provided immediate and improved efficiency and security, and it also allowed you to immediately connect with your patient and focus on the patient rather than the computer when you're greeting your patient in the exam room. Another initiative was providing remote scribes. Remote scribe connects remotely through a speaker in the exam room to help document the visit, help pen orders, and can search the chart for clinical information. The goal was really to improve scribe retention and provide continuity and also provide portability, which really proved invaluable when we needed to shift quickly to virtual care during COVID-19. We also upgraded and trained physicians on a new voice recognition software system, which was faster, more accurate, and allowed our physicians to use their smartphone as a microphone. Again, this provided additional portability during virtual care. We also provided this resource to all network physicians that were employed as well as independent physicians. We've also enhanced at-the-elbow support with our physician informaticists to help improve more efficient use of electronic health record by examining individual physician workflows and customizing improvements. And finally, using Epic Signal, we reduced inbox messages by identifying redundancy and changing such things as routing rules and reducing unnecessary alerts. I really like this quote from Randy Pausch because it truly is the essence of our work. Dr. Pausch was a professor of computer science, and many of you know the author of the last lecture, who died prematurely of pancreatic cancer at age 47. He spent the last years of his life teaching us how to manage our time wisely and how to bring joy and meaning to our lives. I'm asking all of you, are you making sure your physicians are spending their time on the right things? This really is the key, not only to our professional fulfillment, but to our personal fulfillment as well. Let's let doctors be doctors again. As we look at the impact of COVID-19 on physicians, it really has simply exacerbated the known primary drivers of physician burnout. As a result of COVID-19, we've suffered a litany of losses. We've lost patients, colleagues, staff. COVID-19 has threatened our personal and family safety and interestingly, for the first time, job security for many physicians. Safety standards have shifted from optimum to minimum. It's exacerbated known health disparities, especially in people of color. Financial pressures on healthcare organizations have resulted in more micromanaging and hypermonitoring to drive efficiency and reduce costs. And physicians have experienced resource constraints and rationing of patient care. Isolation has increased, more physicians are working remotely, and COVID-19 exposure has required quarantines and reduced opportunities for collegiality and peer support. Overall, the result is a sense of betrayal at the local, state, and federal level by a failed healthcare system. COVID-19 has also fundamentally and forever changed the healthcare delivery system in the ambulatory setting. The accelerated adoption of virtual care has presented many new challenges. We're trying to balance the polarities of increased demand for consumer-centric focused healthcare and still support efficient and healthy work environments for physicians. It's immediately increased our providers' interaction with technology. We've had to move from deployment to improvement rapidly with the adoption of virtual care triggered by COVID-19 and with added access and financial pressure. Virtual care challenges include identifying the right patient, the right visit, right caregiver, right place, and right time. It's required rapid new learning of technology as well as rules and regulatory changes. And we've had to develop new communication skills, recognizing the difference between website versus bedside manner. We've had new workflows with pre-visit planning, patient rooming, and aftercare. But fortunately, we believe that our work that we've already done in EAP has better prepared us to pivot and support the rapid adoption of virtual care. We've previously up-leveling our technical skills of our physicians and leveraging our existing technology. In addition, we've really recognized the value of investing in enhanced relationships with all of our stakeholders, especially with our IT and informatics departments. With the rapid adoption of virtual care, we've also identified the need for closer collaboration with our access and virtual care councils to make sure that the operational and strategic decisions that are made are examined through the lens of the physician. We set new EAP goals related to virtual care, which include now reducing the friction across care channels, allowing seamless transition to different types of visits in a workday, and providing resource allocation to support education and training for provider staff as well as our patients, and to continue our focus on valuing our physicians' time, allowing to really practice at the top of the license. And at this time, I'm going to turn the presentation over to Ann Ostrom, our director of the center, to speak on our work under the Exceptional Practice Experience Provider Communication Council and our strategy in the domain of personal resilience.
So I have an opportunity to share a couple of things with you in my segment. And the first I'd like to talk about is some additional work of the EAP cabinet, which is the work of the, the Communications Council. And then I'll talk about the work of the personal resilience dimension. So with the Communications Council, I think a thing to really go back and consider is the quote that Dr. Kosh shared with us from Randy Kosh. Are we spending our time on the right things? So with time so valuable and so limited, we know that every interaction with our physicians needs to be effective. And we took a look, and as a network, we knew that we could do better. The executive leadership that asked the EAP cabinet to work on improving physician communication, and the council was created and got to work. So we first started by surveying our physicians, and the findings were really interesting. First of all, email is their most relied upon source of information. Secondly, email is their communication preference. And thirdly, they do not read email. So, of course, we have to ask ourselves, well, then how can we be effective? And why don't they read email? The answer to those questions, they get too many emails. They don't find them to be relevant to them. Emails are too long, with the what do I need to do often buried within many, many paragraphs. So this council that got to work included physicians, APPs, marketing folks, IT security, and office administrators. And the first objective was to tackle distribution lists to clean those up. So no longer would our physicians receive multiple emails about the poinsettia sale that was filling up their inbox. That seems to be a real win for everyone. Secondly, this group researched how to most effectively communicate via email. And the outcome of that work was a weekly provider newsletter that was produced on Wednesday mornings at 7 a.m. because that's when most physicians actually read email. The product had to be short, concise, relevant, and easy to read on mobile devices. The reason for that is that over 50% of people read all of their email on their phones. And because people decide within about 3 seconds whether or not they're going to read an email, we needed to order the contents of any newsletter communication like this. Who is this for? What do I have to do by when? Where can I get more information? And I would click for that. And then who can answer my questions? So we piloted this with a test group and found it to be very well received. We know that the newsletter dramatically reduced the volume of emails, and this was invaluable during COVID because we had already introduced this in 2019, and it had quickly become the one-stop shop for communication with physicians and APPs. We also could track the open rate of those newsletters and found that during June, during the height of our COVID season, we were averaging 4,000 views a week. So we know we only have about 1,000 providers, so we were getting folks coming back and re-reviewing those messages. A companion piece to that newsletter was a standard format to use when emailing large groups of physicians, using the same who's this for, what do I have to do by when format, which again really helped improve communication. These tools also gave our Center for Wellbeing a regular forum to communicate about resources. Moving on to personal resilience, that's a dimension of our career fulfillment model that I'd like to talk about. And as you know, personal resilience is that ability to withstand adversity and bounce back. So in tackling that element, that dimension of well-being, I'd like to talk about a couple of strategies that we employed to address this dimension. As you know from Dr. Koss's earlier information about our journey, he shared that we had a speaker come in and educate folks about what burnout is, what the stress looks like, and really make people aware of what those signs and symptoms are. And you know that you can't identify that and make people aware of it and then not provide a resource. The research indicates that physicians typically do not use an internal EAP program for a variety of reasons. So what we did was to contract with the National Behavioral Health Organization, which specializes in providing trained physician coaches. It also has a 24/7 confidential live answer crisis line, counseling services, and concierge services. And because we know that physicians prefer to talk with other physicians, we also know that they're always concerned about confidentiality. So making resources available in this confidential way, external to community health network, really addresses some of those barriers. And that barriers primarily being the mistrust and suspicion that personal issues are kept confidential. Interestingly enough, because physicians are so unaccustomed to asking for help, the concierge service is a great way to get them to recognize that it's okay to reach out. The service has a mobile app, a robust website, assessment tools, and online learning. And we made this program available not only to our physicians and APPs, but also to their families. And we promoted it widely through meetings, presentations, sending materials to the home, putting messages in the physician lounges, and then at every opportunity we got. Our initial utilization was around 6%, and we were really happy with that. To date, we are at around 34% utilization. So having this resource in place during COVID has been a real benefit for all. The second strategy in our personal resilience dimension was to offer opportunities to fight isolation. And we know isolation is a major contributor to stress and burnout for physicians. Our Wellbeing Advisory Council members, first of all, organized and hosted regional social events. These were sort of get-to-know-ya get-togethers, very informal, well-attended, and we got a lot of good feedback from there. And then we surveyed people every chance we got. And one of the things that they shared with us when we surveyed was that we'd love to get together with our colleagues, but we really don't want to take away family time to do that. We'd like to be able to do both. So they asked for a family event. And I'm sharing here a photo of our first endeavor at a family event, which was a fall family hayride. This featured lots of activities for the kids. We had a band, we had great food, we had fire pits, and also featured a service project, which is really important to the culture of Community Health Network. We had more than 225 people attend this event, so we were pretty pleased with that. In addition, we've been able to offer some affinity groups and things that are just based around things that are of interest, common interests, like a hiking club we have and a book club. The family event was destined to become an annual event. And last year we hosted an Indianapolis Indians game with more than 450 people in attendance. Another successful strategy that we discovered, really, was to combine educational opportunities and interest with social events, and of course food. There always has to be really good food. So for example, we wanted to educate all of our providers about mindfulness, and we needed a place to host this and did not have meeting space large enough. So we offered this at Top Golf. So the folks were able to learn about mindfulness, have a meeting, a nice meal together, and then play a round of golf. We also hosted several small group financial well-being dinners with spouses, and this was presented by one of our physicians in our network who's so well respected for providing unbiased financial education, and he has an MBA in finance, so unfortunately we tap him quite often. Lastly, I'd like to share something that we're really excited about that we tried out last year for the first time. We hosted a physician educational retreat that was focused on financial well-being and financial literacy. This was offered to physicians and their spouses, and we also were able to award CME credit for that. We had national external speakers and internal speakers who focused on a variety of topics that would appeal to folks in the areas of financial literacy. And we know from surveys of our physicians that this is always something that they're concerned about and feeling ill-prepared for. So we thought that combining this educational opportunity with a social and collegial event was a good way to go. We also introduced something we're sort of proud of, which is our own Genius Bar. At the break, our informatics team had set up high-top tables with a bar menu, and this menu included topics that they could assist our physicians with from a technological standpoint, such as smart sets or voice recognition or what's coming up that's new in technology. We even had some doctors come with a whole list of things that they wanted to ask about. And the great benefit of this really, not only that it helped the physicians, but it also helped the informaticists make a personal connection with people that they'd only worked with on the phone before. And oftentimes these phone conversations were problem solving in the midst of a really busy day. We offered this at a beautiful location off-site, the French Lick Springs Resort Hotel, and it's only about an hour and a half away from Indianapolis, so it wasn't too far. It was quite accessible and a great place to host a meeting. In addition, this provided a chance for some really casual social interaction away from work with colleagues, but also with spouses, and allowed us to address a well-being concern. So we felt like we had a pretty winning formula there, and we're hoping and planning to do it again this year. In fact, we would have done it this past weekend, but we had to cancel because of COVID. So you might be saying to yourself, well, this is all well and good when you can have activities and host events, but what did you do during COVID? Well, we primarily went virtual. We had an opportunity to meet with our Wellbeing Advisory Council every week. That was something that they were interested in doing. And all of us made a lot of personal contact with our physicians. And when we hosted things like focus groups virtually, or the virtual physician lounge, or the virtual affinity group, we all reached out and asked folks to join us. So we made a lot of personal connections and invitations. We also increased our focus on connecting to resources. So through the Weekly News Wednesday, which is our weekly newsletter, we were able to really promote resources like mindfulness. We created videos on things like financial survival. We made people aware of things like Headspace, and we also did a mailer to the home. So we spent a lot of time really trying to put those resources out there. Lastly, we are currently focusing on a new series that we're calling Making Connections, and we've tried to identify ways that we can connect with more people in smaller groups more often. So what you see here is a picture of our first drive-in movie night, which we hosted a couple of weeks ago with great success. We also have on tap several things like a casual dining experience, which is an online streamlined cooking class where folks can get the groceries ahead of time and cook along with some of our physicians. And that's being offered in a couple of weeks. We offered a virtual wine tasting educational session, and in the future, we're going to be offering more financial chat. So lastly, I'd like to share a quote from one of our physicians about this effort that we've made with our Making Connections series. This is just one example of some of the feedback we received. This physician said, "Thanks for planning and hosting the drive-in movie night. Thanks so much for my family and I had a wonderful evening. It was much needed. We really miss going out to movies as a family, and this made it possible. It was a great diversion from our otherwise stressful life." So with that, I would like to go ahead and turn it over to Dr. Hearn to talk about something we're really so proud of, which is our Physician Leadership Academy.
Fantastic. Thank you, Anne. So yeah, I'd like to finish up our presentation by just sharing a little bit. I'm going to go back just a moment. Sorry, there we go. Talk about our Physician Leadership Academy and a little bit about what we've done to create a fantastic experience for our medical directors through learning. You know, what we found 3 years ago was that many of our medical directors who've been placed into a leadership role have very little background or training in leadership development. And they're often reluctant leaders, I'll call them, because they've sort of been tapped on the shoulder. Hey, we need you to be the medical director of this practice or this department because so-and-so, just decided they're no longer interested. And not everyone has really had the experience of having some training. And often organizations will bring in, send people to outside programs or conferences, or try to bring in external speakers. But what we really found in doing our legwork to build this leadership academy is that we wanted something that was owned by our own organization, that we developed our own leadership competencies, and that our programming was led in part by a physician, myself being in that role, because physicians really want to learn from other physicians. When you have your talent development or human resources department do this type of training for physicians, sometimes there's a little bit of a disconnect. And we had that experience a few years prior when we tried to go down, that route in terms of developing our physician leaders. And so I was asked to kind of build a program, and we went around and looked at other organizations across the country and did research and had focus groups and brought together various medical directors from different roles in our organization and figured out what do people have the appetite for, and what are the highest need content that we need to cover in order to provide our medical directors the backbone of what they need to be successful leaders. And so these are our homegrown physician leadership competencies that we developed as an organization. And we break our one-year leadership academy into these 3 trimesters, I'll call them, starting at the beginning of the year with the leading from self, then moving into leading others or leading a team, and then leading at the organizational level. And I'll just kind of briefly run through how we do this. We first start out the year by spending a lot of time on the role of the physician leader and helping kind of level set what that means, and also talking about self-awareness. It is very interesting when we look at our evaluations at the end of the year on our Physician Leadership Academy. This self-awareness work is some of the most highly rated and most frequently commented on aspect of the Physician Leadership Academy. Most medical directors have never done this work. We do self-assessments. We ask our medical directors to go out to team members and bravely ask for what are some of their blind spots, and we coach them on how to have those conversations. And they really gain a lot of insight, and they learn that not everyone thinks exactly the way they think, and they have to tailor their leadership style based on their different team members. Building trust on their team is a key part of some of this work, and also the courage to speak up and act. Sometimes our medical directors are tentative or are nervous to kind of take the lead when a situation is difficult, but we focus on really needing them to step up when things get challenging on their teams. So that's the first part of the year. The second part of the year, we spend time focusing on communication, crucial conversations. We teach from that Crucial Conversations book that many of you may know about. We have them do role play. They actually jump right in and dive into that work. We talk a lot about building relationships and influence. Sometimes medical directors will say, well, if I can't fire someone, then how can I get them to be accountable or do what I need them to do? And we spend a lot of time trying to shift that perception over to it's more about influence and building relationships with key stakeholders and people that you're working with so that you can help influence them to change when they need to. And that's a key part of our this trimester on leading others. The other thing is listening. We spend a lot of time talking about how to be a good listener as a leader, not just delivering information, but receiving information and providing that information up to more senior leaders in the organization. And then lastly, we finish out the year with leading from the organizational level. We talk about process improvement. We educate folks on our organizational we call it our 7-step methodology of the way we improve. That's our process improvement methodology. Talk about quality improvement, how to drive not just process improvement from what the methodology is, but also from the leading change and people side of How do you move people through a process improvement and get them to adopt it? And also, during this last part of the year, we try to address some of the national landscape of healthcare in terms of value-based care and where is our organization going in the context of the national healthcare landscape, as well as healthcare finance and not just healthcare finance in our organization, but also kind of nationally what's driving some changes that all of our organizations are having to make right now. So this is the content and what we've built, the scaffolding around which we've built our Physician Leadership Academy. We try to reinforce the messages of this content in different medical director meetings, or when we have a retreat of all of our medical directors once a year. We constantly are reinforcing this. So we have created a shared language around what does it mean to be a leader in our medical group. And I think that thread sort of just continues and permeates throughout throughout all of our different meetings and events, and it's just a shared language has been created through this Physician Leadership Academy. The thing that I like to, share a little bit about the Physician Leadership Academy, it's not a lot of time. We ask people what they were willing to do in terms of a time commitment when we built the academy, and ultimately we just got people really felt that they could just provide a couple hours a month. Our medical directors are all very busy. They have often just 0.1 or 0.2, 0.3 FTE dedicated to their medical director role. And so we decided to just provide those 2-hour sessions once a month. And when they do get together, they have dinner, they network, people who have worked together for years are able to get in the same room together and have conversations and share experiences. And we do a lot of dialogue during our Physician Leadership Academy where they can share their own experience and have small group discussions at the tables. Unfortunately, with COVID, we've had to pivot, and I'll talk about that in a minute. And at the end of the Physician Leadership year, we have a big celebration and make a big deal out of the end of the year because they truly have committed to their own development and learning and completed that year. And we have our CEO and our chief physician executive and other key physician leaders in the organization come and celebrate with them. And it's a whole lot of fun, and everyone really enjoys it. And each year we have about 30 to 35 providers in each cohort. We're completing our third cohort right now, and there's always an appetite for people to enter the academy who've not yet done it because they hear good things and they hear that it's high value learning for them. So the other thing that we've done, let's see my slides, there we go. The other thing that we've done during COVID is we've had to pivot a little bit. Obviously, like most of you, or the learnings that we do now are offered virtually, so our Physician Leadership Academy is offered virtually. In addition to doing the Physician Leadership Academy, we have other offerings to help develop our medical directors, such as new medical director onboarding. For folks who haven't yet started the Physician Leadership Academy, we kind of give them a primer to get them going in their leadership role. We offer on-the-fly coaching through virtual leadership lounges where medical directors can drop in and ask questions of us in the center. And so we've definitely tried to pivot and provide more learnings more often in a virtual setting and adapt as best we can to this environment of COVID. And I will say that a lot of the work that we did to develop our physician leaders, I'm so thankful we did it the 3 years prior to COVID, because I do think it helped us be a little bit more resilient as an organization coming into this crisis and being able to help lead people through change. It's obviously been challenging for us, like everybody across the country, but I think that the foundation of having our medical directors really trained up in their leadership skills has helped us be more resilient. So just as we close, and then we'll open it up for questions, I just want to summarize by, I hope you were able to hear a little bit about our journey from starting, from setting the tone of, hey, this is our culture of well-being, burnout is real, it's important, we need to educate people about it, we need to remove the pebbles in the shoes and provide people resources such as remote scribes and a clear newsletter every week and the tap in, tap out, and the voice recognition tools. We need to provide them counseling, coaching, and concierge services so they can go outside of the network if they feel they need resources and help, provide a lot of collegiality events to reduce isolation, and then provide physician leadership training. But all of these things in isolation, they're tactics, right? They're things that you can do within your organization. But I think when you zoom out and think about how we made our journey happen, it's really about transforming a culture. It's saying that we are prioritizing as a health network that physician well-being is extremely important to us, as well as having strong, well-trained physician leaders. And we have had continued, unwavering support from our most senior leaders who have resourced this work, both in their words and in financially resourcing it and making sure that we have what we need as a team, our small, mighty team, that we have what we need to do things that are high impact, to make a difference for our physicians and our physician leaders. Our team has worked by talking to the folks across the network, a lot of building relationships. As I said, we are a small team, but we have gotten our work done by creating a lot of relationships across the organization and really listening to what the pain points are of our customers. And I think it's important to have physicians like Dr. Koss and myself leading the work. We need people like Ann and others in our center, but if you have physicians leading this work, it sort of stresses to your providers how important this work is, and it's someone that they can relate to that is in the role. And then the last thing I would just say is never let up. We're constantly remessaging things, putting out information in our newsletter, coming up with new ideas, coming up with new initiatives, trying to pivot and address new pain points that are occurring for our physicians. And so the message has to be from the very top that this is important work and it needs to be resourced and it needs to continue to be resourced. So we appreciate the opportunity today from Becker's and Cigna to share about our experience at Community Health Network. Thank you for your attention, those of you on the webinar today. And now I'd like to turn it over so we can answer any questions that the audience may have.
Great, thank you so much. So there are lots of questions, so I will get through as many as I can. So can you talk about funding for the overall well-being program and also about funding for the individual provider outreach programs where you have events to work on, having folks get together with their families and friends, and how do you charge for those, and describe a little bit about funding for that as well.
Mm-hmm. Well, I would say that this. Oh, go ahead, Anne. Do you want to?
No, go right ahead. Thank you.
Okay. Yeah. So we're very fortunate that our physician group has created a budget and resourced a lot of this work, and we do not charge. We try extremely hard to not charge for the events that we have, and so we generally don't. We are mindful of our budget each year and try to find. I always say that we're always talking as a team. How do we find the high impact activities with that are sort of low cost and have the biggest impact? And we've had partnerships with our foundation, like the Wellbeing Retreat you saw. We did have some donations from our network foundation, but essentially this is a cost that the network has to be willing to invest in, because there is a downstream return on investment if you do this work. But we don't charge for events. So I hope that helps a little bit. I don't know if Anne or Kevin, you want to add anything to that?
I was just going to add, for the educational retreat that we offered, that event was free, but we did ask that we were able to access CME dollars that were provided by the network. So we did ask that we allocate $800 of their CME, and a lot of times those dollars go unspent. So that offset what might seem to be an outgoing expense. The other thing I would mention that we've tried to do a lot is to offer a service event or service activity. So, for example, the movie night that we hosted, our center absorbs the cost, but we ask in lieu of admission for donations to our foundation. So, you know, and with the hayride, we did the same thing. Your price of admission is to bring something for a child in need. When we had a list, coats, hats, we collected hundreds of items. So, so that's been helpful.
Great, thank you so much. And a lot of your programming seems to be focused on physicians. How do you support advanced practice providers and other clinical staff in terms of burnout and well-being?
Yeah, that's a great question. We try to incorporate all of our advanced practice providers in many of the activities that we do. Although the center is really named the Physician Center for Physician Wellbeing and Professional Development, we're very inclusive. Most of the activities that we do involve all of our advanced practice providers. For instance, our family events, our affinity groups, those are all open to all of our advanced practice providers. Our Vital Work Life program that supports coaching, concierge, and counseling program is free to all providers. That's all of our employed advanced practice providers and physicians and their families. In addition, we have just named a director of well-being for advanced practice providers for the network, who's going to help coordinate resources to help support the needs of the advanced practice providers. Unfortunately, you know, the drivers of burnout vary depending on any particular physician, their practice, and the environment they're in. So the same thing holds true with any of our advanced practice providers. Their needs are different. Some of their drivers of burnout are different. So it's very hard to cookie-cutter approach that's going to really serve the needs of every individual provider in the network. So we have focused on physicians primarily because their needs are really very unique. They tend to be the most affected group. They're definitely a most critical component of the healthcare system, particularly with their leadership in the delivery of healthcare. And so those are the reasons, and it probably is the biggest business case to be supporting physicians when you look at physician turnover and the effect it has on the performance of a healthcare system.
Okay, thank you for that. And then, you know, you've done great work, and it seems like you have quite a team together to support physician well-being. How many folks are on your team? How many FTEs are supported, and how big a program do you need in order to start a physician well-being program?
So
can I take that one?
I'll talk about. Oh yeah, sure. Go ahead, Ann. Sorry.
Well, jump in. Dr. Cross is encouraging me to jump in on this one. Sorry. I would say that, you know, we started with 1.0 FTE, which was my role, but then Dr. Cross, I believe, is at 0.4, and Dr. Hearn, I think your role is less than 0.4 because you have other responsibilities. But the key to getting this work done was to align with our stakeholders, and so very early on we identified those folks. I know Dr. Cross mentioned we invited them to our session on recognizing burnout, but we also continued to meet with those stakeholders every month. So if we needed to get something accomplished, we could reach out to our marketing folks and they would help us. We could reach out to our IT folks or informatics folks and they would help us. So we very early on sort of expanded our reach pretty extensively, and as well as the Physician Wellbeing Advisory Council. Those physicians are very committed. They attend a meeting every month, and Dr. Hearn leads an advisory council for the Physician Leadership Group, and the same thing. So those folks then become an extension. So Tricia, go ahead and add to that if you would, please.
Yeah, I think I agree. We have a small, mighty team, but we are extended by all of those stakeholders, and people want to be a part of this work because it is. It's important, and people see the value, and so we're in a fortunate position that I think people want to engage in this work and are willing to volunteer their time, not volunteer, but contribute and go above and beyond their day jobs to say, I want to be a part of this important work.
Great, thanks for your answer. And pivoting to the Physician Leadership Academy, maybe Dr. Hearn, you can answer this. Have you noticed a change in the graduates of the Physician Leadership Academy and their relationship with, say, community groups, health plans, patients, their colleagues?
Yeah, you know, we are actively looking at sort of measuring this more formally right now by performing a formal leadership index and having people evaluate the performance of their medical directors. I will say that just as a sort of an outside observer who's been a part of our medical director group for 5 or 6 years, I do see that we've created a culture where the leadership tenor of our group has evolved, and we see that people self-awareness has improved, their ability to be in dialogue, their ability to have difficult, crucial conversations, to step up and handle conflicts or handle, you know, disruptive behavior in their areas has improved. I don't have any specific measurement related to their patient interactions, but we are actively working on measuring, you know, what do we see in their leadership behavior, and then what does that do in terms of the engagement and burnout of the group that they lead. That's a great question.
Thank you so much. And let me pivot to Dr. Koss. So you've used a lot of technology to help decrease the burden of workflow on your physicians. Can you tell us what's been most effective? What voice recognition software has been most useful? What things have you found that has really been important to physicians in decreasing their workload?
Sure. We have, I think, over 800 providers now, that's physicians and APPs, that are using our voice recognition software. We're using a product called Fluency Direct from a company called Acuity. And we chose that because when we looked at it, our technology group that did the assessment on looking at the available technology just felt that it was a better fit for what we were trying to accomplish. We felt it was faster, it was more accurate. We liked the idea that you could use your smartphone as a portable microphone. We also like the licensing component of it, which would allow us to incorporate our independent and our employed docs, as well as our APPs to use the software. And they're also the same company that is providing our remote scribe service. I think that, you know, the biggest impact clearly was the single sign-on, because that affected every caregiver, and I think no one would ever want to go back to having to log in and key in every time they changed workstations. I mean, that was huge. It was a quick win, and definitely improved the efficiency, and I think just the connection with the patient immediately. I think remote scribe has had a big impact, and we could spend a lot of time talking about that, but we offered remote scribes primarily from the standpoint of looking at the most effective providers. And this was offered as well to APPs as well as physicians. And we looked at people who were really struggling, and we did this by an application process, but we also did it through referral from our joint medical directors and our practice administrators. We looked at people who were spending way too much time work after work, too many minutes in notes, and we have that data, fortunately, that we can mine that data through Epic. So we used Epic signal data to really identify some of our people that appear to be struggling the most, and then we rank them, and then we have a very sophisticated process where we go out, do an assessment. And what's interesting is we found that many of the folks actually may not need a remote scribe, but some of their problems had to do with just inefficient use of the electronic health record, and sometimes with our informaticists having the opportunity to really go at the elbow with them, we could solve some of their problems without necessarily requiring that they would benefit from a remote scribe. So there's a lot of work that was done on this, and so far we've been keeping track of our results and have really had some significant improvements with the folks that have been using remote scribes. They're actually now matching up with people that have not required scribes in terms of their efficiency, and we measure work after work, time and notes, and work after scheduled hours, and significant improvements over the last 6 months in those folks that are using remote scribes. And I would say probably 95% of those that have remote scribes keep the remote scribes.
Well, thank you very much. And with that, I want to thank our panelists again, Dr. Tricia Hearn, Dr. Kevin Koss, and Ann Ostrom. We understand how important provider well-being is to our first responders in healthcare. These discussions provide a framework to create and or improve well-being programs. On another note, if anyone who's listening feels overwhelmed or burned out, please make sure you take time to reach out and get help. Your EAP or employee assistance programs can be a great first step with that. It's extremely important that we take care of ourselves, especially as we start seeing the pandemic worsen and see the effects of our changing environment and adapting on our own well-being. So again, please take care of yourself and stay well, and thank you for joining us today.
And a final thank you as well from the Becker's team. Dr. Cross and Dr. Hearn and Dr. Demuth, thank you for an excellent presentation, as well as Cigna for sponsoring today's webinar. Attendees, enjoy the rest of your day, and we look forward to having you join us for future presentations.